Good morning. Today we're going to talk about the sixth cranial nerve palsy. Sixth cranial nerve palsy. When I talk about the sixth cranial nerve, what comes to your mind? It is that nerve which innervates the lateral rectus muscle. It is that nerve which gives innervation to the lateral rectus muscle. The normal function of the lateral rectus is to pull the eyeball outward, or we say it helps in abduction. Abduction. It takes the eyeball away from the midline. That's the normal function of the sixth cranial nerve. So the sixth cranial nerve is also known as the abducens nerve. It's the most affected of all the ocular motor nerves. Remember, there's difference between oculomotor and ocular motor. Oculomotor is third nerve, but if you hear ocular motor nerves, it refers to all the nerves that supply the structural muscles. Okay, all right. So, what are some of the for example, how do you identify that there is a sixth nerve palsy? As you can see, in the right eye, the patient is looking straight ahead and is clear. But the left eye, okay, in the left eye, the eyeball has moved inwards. Look at the corneal light reflex. There is a light which is on the cornea, okay? The right eye, that light is centralized here, but in the left eye, it has gone almost to the limbus. That means the eyeball has shifted inwards. Okay. All right. What are some of the etiologies or causes of abducent nerve palsy? It can be caused by trauma. Yes. It can be caused by intracranial aneurysms. It can be caused by ischemia itself to the nerve. Sometimes it's idiopathic, but you also have demyelination diseases like the multiple sclerosis. Okay. Sometimes too it can be caused by microvasculopathies. What do I mean? Hypertension, diabetes, hypercholesterolemia, and sometimes too, remember, it can be caused by intracranial lesions, okay? Intracranial hemorrhage, intracranial tumors, raised intracranial pressure. Of course, depending upon where the lesion is located, okay, the cavernous sinus, so it may also be found as part of syndromes. All right, so like cavernous sinus syndrome, orbital apex syndrome. Okay, so that is it for its etiology. So what are the clinical features? Okay, the clinical features of sixth cranial nerve palsy. Okay, we'll start with the symptoms, and after that we talk about the findings. A patient will come to you telling you that for the past few days things have started becoming double, and that he or she is not capable of moving the affected eye laterally in one particular direction. So what they will tell you is that they've started seeing double, and apart from that, they cannot move the affected eyeball into one particular direction. What does this imply? That there is a problem with movement of one of the structural muscles. Another thing that you can delve into and probe more into is if they say they are seeing double, the thing they are seeing double is one thing beside the other or one is on top of the other. And they will tell that one object is beside the other because it's the horizontal muscle which has been affected. All right. So because the left eye is not looking straight, okay, things will appear double, and it will not be on top of one on top of the other. No, it will be one object beside the other. In this eye, it is the left eye which is what affected. But in this other eye, it is the right eye which is what affected. So another thing, they can also tell you that when they want to read, they want to watch their mobile phone, it is quite a bit easy. Okay, but when they want to look into the distance, when they call on the lateral rectus muscle to contract, then the double vision becomes worse. Okay, and they can also tell you that sometimes the facial tense, all right, make the double vision become better or worse. For example, if she turns her face, remember the vestibulocular reflex or Dorsey phenomenon. She turns her face into the left side. Okay, if she turns her face to the left side, the eyeballs will go to the right side. The left eye automatically is at the right side. And when she turns the face towards the left, okay, the right eyeball will automatically go to the right side and the double vision will what? Will reduce. I repeat, if she turns her face towards direction of the area, the side where the palsy is found, in this case she turns her face towards the left side, the right eyeball automatically moves to the right side. So both eyes will be found at the right side and the double vision will reduce. On the other hand, if she turns her face to the contralateral eye which is not affected, in other words to the right side, her right eye will come to the left side, but the left eye cannot come to the left side, and that will give way to a lot of the double vision. The double vision will what? Will be worse. So remember that when someone talks about double vision, one object could be on top of the other, or one object could be what? Beside the other. If it's a vertical muscle, be it superior rectus, inferior rectus, superior oblique, inferior oblique, then they will tell you that one object is above the other or below the other. But if it's a horizontal muscle, like the horizontal, like the medial rectus or lateral rectus, then they will tell you that they see double, but one object is what? Beside the other. Why won't you see double? You won't see double yourself because your eyeballs are well aligned. When the right eye is looking straight, the left automatically should look straight. If this alignment is lost, then double vision sets in. So they will tell you that they see double and they cannot move the eyeball into one particular direction. And that when they look at things which are near, the double vision reduces. But when they look at things which are far away in the distance, the double vision becomes worse. At the same time, they will tell you that when they turn their face towards the side where there is palsy, all right, the double vision becomes better, remarkably reduced. But if they turn their face or head towards the unaffected side, the double vision becomes worse. And that usually one object is beside the other. So these are the symptoms that they will tell you. What clinical signs can we elicit from a patient who has seized cranial nerve palsy? Remember, the muscle which acts in opposite direction or function to the lateral rectus is the medial rectus. So, if remember this eye, it is the right eye which is affected. How do you know that one eye is affected and the other eye is not affected? We call something the corneal light reflex. Corneal light reflex. In the right eye, this is the corneal light reflex as I'm pointing at it. If you shine light at the bridge of the nose, okay, in an arm's length distance from the patient, shine light at the bridge of the nose, and you see that there will be light on the cornea, light on the cornea. If you look critically in the left eye, the corneal light reflex is centralized. It is not at the geometric center, but for your understanding, I'll tell you that it is at the center of the left eye. It means the left eye is well aligned. It is straight. But the right eye, if you look critically, you realize that the corneal light reflex is almost going to the temporal side of the limbus. What does it imply? It means the eyeball has shifted inwards. Remember that the position of the eyeball is usually opposite to where the corneal light reflex is found when the eyeball is not straight. What I mean is that if you find the corneal light reflex a bit temporal to the limbus, it means the eyeball has shifted inside. Let me give you this other example. Look at the corneal light reflex in the right eye. Okay, it's centralized here. It means the right eye is straight, and that is the eye we want. But the left eye, it is not centralized. It's almost shifted towards the temporal limbus. This implies that the eyeball has shifted inwards or towards the nose. The question is, why should the eyeball shift towards the nose? It's simple. The answer is simple. The muscle which acts in opposite function to that of the lateral rectus is the medial rectus muscle. So now that the lateral rectus is weak because the sixth nerve, cranial nerve, has got a palsy, the medial rectus takes over and pulls the eyeball inwards. And that is how come they are not able to move the eyeball laterally. So apart from doing the corneal light reflex test, you can also do extraocular motility test. You ask the patient to look in all directions with the two eyes open. Okay, they move to the right, move the eyes to the right, they move to the left. You realize that the left cannot move to the left side, but the right eye moves medially. You ask them to look up, down, in fact, in all directions, the eyeball may be able to move, but the lateral movement of the affected eye becomes difficult for the patient. In this case, patient cannot move the eye to the right side. So they tend, if it is long standing, they tend to develop what we call compensatory mechanisms. Compensatory mechanism, how? Remember the vestibulo-ocular reflex or Dorsey-Bell phenomenon. In an attempt to reduce the double vision, because if there's always double vision, they can fall down. It creates ambiguity on their minds. They see two things, which one is fake, which one is correct. When they are crossing a gutter, they see two of them. Crossing road, they see two. So if a vehicle is coming, they see two, which is fake, which is correct. In an attempt to overcome this state of ambiguity on their mind, what do? They develop what you call compensatory mechanisms. Compensatory mechanism. Students, as I taught you the other time, if you turn your face or your head to the right side, if you turn your face or head to the right side, automatically the eyes will move into a contralateral direction. They will move to the left side. Okay, so the left eye which is affected will automatically go to the left side. The right eye which is now automatically fixed to the left side becomes aligned with the left eye. So the two eyes will be seen looking to the left side. In this case, the double vision is reduced or basically absent depending upon the amount of deviation. And they are okay because they don't want to see double. But so they will usually turn the face towards where the palsy is the site where the palsy is found. Okay, in an attempt to reduce the double vision. So in this case scenario, so it is the left cranial nerve pulse, cis cranial nerve pulse. So they will turn their face towards the left. When they turn their face towards the left, the right eyeball will move to the right side. It will move to this corner. And this one is already fixed at the right side. Okay, so the two eyes will be looking to her right side. That makes her reduce or let disappear the double vision. Okay, so that is the compensatory mechanism that they usually have. So they may have face tilt or head tilt towards the side where the palsy is found. So in her case, she wants to reduce the double vision. She will turn her face to the left side. Okay. In this other case, if she wants to reduce the double vision, she will turn her face to the right side. Okay. If she does in the contralateral side, the double vision will be worse. So that is it. Sometimes there are clients in whom we request for imaging, be it CT scan of brain and orbit, or sometimes MRI, magnetic resonance imaging. We request for this type of imaging, but you don't request it for all patients. So, in which class do we expect to get imaging done? Well, patients who are younger than 55 years with no vasculopathy. What do I mean? Around 55 years, many people in the population will develop hypertension, diabetes, hypercholesterolemia. Okay, but so if they have none of these, then most likely the cause is intracranial, right? There's a compressing lesion, increase intracranial pressure, a tumor, a cavernous sinus syndrome. So in that case, it's mandatory to request for what? Magnetic resonance imaging. Magnetic resonance imaging. Another group of people who qualify is those who have history of carcinoma in any other part of their body. You have taken very good history. You have not been able to elicit the cause of the cis cranial nerve palsy. Then, in that case, you can, and they have a history of carcinoma, then you can ask for what? MRI of the brain or CT scan. The reason is that there could be metastasis from or to the brain, which is causing the cis cranial nerve palsy. Another indication is when the cis nerve palsy is bilateral. If it's bilateral, it also calls for what? Neuroimaging. Sometimes to after thorough examination, realize that the client has disc swelling or papilledema. Okay, disc swelling or what? Papilledema. So papilledema will tell you that in fact there is most likely raised intracranial pressure. In that case, one of the features of ciscranial nerve of raised intracranial pressure is what? Ciscranial nerve palsy or the Abducens nerve palsy. Okay, we can also ask for MRI or CT scan when there is no improvement or if the nerves become or if other nerves become involved. What do I mean? After waiting for 6 months to 1 year, there is no improvement in the ciscranial nerve palsy. The angle of deviation becomes consistent, doesn't change, or even you realize that sometimes other nerves become involved. Then you need to do neuroimaging to find out where the problem is coming from. In the youth or in the young people, sometimes it's just trauma, which is the most common cause. Something hitting their eye or their head. Okay, so those are the indications for the MRI. Remember that There could be differential diagnosis. It shouldn't be like anyone in whom you see eye deviation towards the nose has what? Cranial nerve palsy. It could be, or it could sometimes it may mimic other types of diseases. So, what are some of the differential diagnoses of cranial nerve palsy? It can be myasthenia gravis. Okay, in myasthenia gravis, remember that the muscle weakness becomes worse as the day grows. Okay, as the day grows, the muscle weakness what becomes worse. So they may develop blepharoptosis, alright, which becomes worse from morning till evening, and of course, it may affect some of the structural muscles, but the most affected will be the obliques at the initial stages of the disease. And of course, the test that you do will help you to differentiate. Then you have restricted thyroid myopathy. Restricted thyroid myopathy. All right. So, if in thyroid eye disease, the media rectus becomes affected and restricted, all right, it will mimic the same seasonal pulse. But remember that in thyroid eye disease, they may have hyperthyroidism, hypothyroidism. They also tend to have, depending on whether hyperthyroidism or hypothyroidism, thyroid stimulating hormone problems, FT3, FT4 derangement. But then the eyelid, you realize that there's lid retraction. There's eyelid retraction. So you can also have medial orbital wall blowout fracture with entrapment of the medial rectus. I repeat, medial orbital wall blowout fracture with entrapment of the medial rectus. So you could have a trauma happening to your orbit and the medial wall gets a fracture. All right, if the medial wall gets a fracture, as I tell you, as I told you in previous classes, the medial wall is the thinnest of all the walls within the orbit. In fact, that is why it's called lamina papyracea. So it can easily get some fracture within the least amount of trauma. So when there is a fissure, an entrance, an opening through trauma, the medial rectus muscle may be entrapped, may be captured inside this orifice, okay, and cannot move. In that case, the eyeball will be deviated medially. So we call something fall duction test. The fall duction test will help you to get the difference between whether it is a cranial nerve palsy making the eyeball deviated inwards, or is a restrictive problem, as in an orifice within which the medial rectus has entered. It has captured the medial rectus and entrapped it, preventing its movement away. So we could also have orbital myositis of lateral rectus. Okay, so if the lateral rectus gets what you call the orbital inflammation syndrome, okay, orbital inflammation syndrome, it cannot pull the eyeball laterally, then the medial rectus takes over. All right, so in that case, there will be inflammation within the eyeball. It will not be as quiet as this. Then we have the Duane syndrome. Duane syndrome. Okay, what is Duane syndrome? It's defective abduction and narrowing of palpebral fissure. Okay, so in Duane syndrome, it is not just that the eyeball is deviated inwards. No. So apart from the eyeball being deviated inwards, there is reduced palpebral fissure. There is some amount of blepharoptosis. There is reduced aperture within the eyelid. So between the superior and lower eyelids, there's what? Reduced palpebral fissure, okay, or narrowing of palpebral fissure. Then we can also have what you call convergence spasm. Convergence spasm. So both medial rectus muscle overcontract. Okay, When they both contract, then you realize that the eyeballs have moved in automatically. Alright, two of them moving automatically. Then we also have divergence paralysis. In other words, the eyeball cannot move outward. Okay, they can diverge outward. So that is divergence paralysis. So these are some of the differential diagnoses which you go through your mind as you talk about cranial nerve palsy. Alright. Then how do we manage these patients? Of course, you listen to the history, and after examination, you may also ask for neuroimaging, and after everything, you sit down and find out the etiology. So the management is actually dependent on the etiology. It depends on etiology. But what do we usually do? If it is idiopathic, okay, we float the patient up for a period, or even sometimes when it is traumatic, we float the patient up for a period of 3 to 6 months, expecting spontaneous resolution. So if then we keep measuring the amount of deviation that there is within the eye, okay, using prisms. There are certain clients who automatically will get it resolved. If it persists, then we do what we call patching. Patching, okay? But if you're able to find an identifiable cause, then we treat it as such. For example, if it's caused by microvasculopathy, so let's say hypertension, diabetes, hypercholesterolemia, all we need to do is what? To control these factors. Normalize the diabetes, the sugar levels. We normalize the blood pressure levels. We normalize the cholesterol levels. And for a period of 3 to 4 months to 6 months, the patient should be able to get the proper alignment of the eye, and the cranial nerve will no more be present. If it is an intracranial lesion, until you solve it, the cyst nerve palsy will persist. And then, assuming we are in an observational stage in an attempt to control the risk factors which led to the cyst cranial nerve, within that period, we do what we call patching. Patching. What do I mean by patching? You give the patient glasses, all right, and then you patch the inside of the side which is affected. So although the two eyes are open, patient is using only the right eye to see. That helps them to reduce or to let go the double vision, which is one of their greatest worries. Okay, if it's in a child, we also do what we call the patching bit, okay, to avoid amblyopia development. So in the chart, what you do is that you may end up patching the proper eye, and then so that they can use the affected eye to exercise and see around, so that the eye will not become lazy. Okay, so we so all these methods, if they fail, then we do what we call surgical intervention to correct the cyst cranial nerve palsy. Surgical intervention. So, which muscle will you strengthen? Which muscle will you weaken? Students, the medial rectus muscle is overacting, and the lateral rectus muscle is what? Weak. I will ask you in class, which muscle do you strengthen and which muscle do you weaken if you have to do surgery to correct a cyst nerve palsy which is not correcting on its own after observing it for 6 months to 1 year. There's no correction. Patient still has double vision. What muscle will you strengthen? What muscle will you weaken if you have to go surgical? So, at this juncture, I thank you very much for your rapt attention. We're going to meet in class. If you have any difficulty, keep them, and then you can have the chance to clarify the matter. See you again. Learn very hard.